Today we will be learning about the ECG changes in COPD. This is the ECG showing in a patient of COPD. The first most important change and the most common change that is seen is the right axis deviation. Here we can see in the lead one the QRS complex is very small, whereas in AVF the QRS complex is very large. This indicates the axis of the ECG is slightly towards the right. That is, there is first right axis deviation. Second, due to overinflation of the lung field, there are low QRS complexes, low voltage QRS complexes. You can see here in all these leads, QRS complexes are very, very small. Second, low voltage QRS complexes. Third, another most important sign, which is P pulmonale. P pulmonale is P wave more than 2.5 mm. It is best seen in lead 2. In COPD patient, it is also seen in lead. It is seen in 2, 3, and AVF, and sometimes in V1 also. That is in the inferior leads. There it is seen. Then fourth change that is usually seen is, and then rest of the changes that are seen are when there is involvement of the heart, right-sided heart. Here in this ECG of COPD patient with right side heart involvement, we can see the lead 1 is negative and AVF is positive. This clearly indicates the right axis deviation better than the previous ECG. Then second is right ventricular hypertrophy. It can be seen in the V1 lead when R wave is more than 7 mm. Here we can see R wave is approximately 2.5 large boxes, that is more than 7 mm. So RVH is indicated by, there are two criteria of RVH. First is R wave is more than 7 mm in V1. It can also be written that R by S ratio in V1 is more than 1. Clearly we can see R wave is so tall and S wave is very small. So R by S ratio is more than 1. Second sign is in V6. Second sign is in V6 S wave are deep. Now in normal patient the S wave should not be so deep in V6. Deep S waves in V6. These are the two findings of RVH. Third, in the patient of COPD, when there is involvement of the right heart, it leads to the poor progression of the R wave. That is, in V1 there are large R waves, and in V1 in V6 there are small R waves. As we can see, large R waves in V1 there are and these R waves are very tall in the right sided leads, that is the V1, V2, and they are very small in the later leads, V6. So this is known as the poor progression of R wave. This is very important sign. Poor progression of R waves. Then another sign which is seen, that is the RV strain pattern. Now what happens when there is RVH? It leads to the straining of the RV, right ventricle, and RV strain pattern is T inversions in here, and we can see there are T inversions in V1, V2, V3, usually in the right sided and the little bit of anterior leads. V1, V2, V1 to V3 there are T inversions, and these T inversions, they are pulling the ST segments toward themselves like this. These ST depressions in V1 to V3 along with T inversions are indicative of RV strain in setting of RVH. These does not indicate MI in the patient because these are not the primary ST depressions. They are primary T inversions with ST segment dragging. One should not confuse these with coronary artery disease or acute coronary syndrome. These are not these things. This pattern is known as RVH with RV strain. And this is very, very important to distinguish it from the STEMI or the non-STEMI patients. So these are all the ECG changes that we will see in this COPD. There is a mnemonic for this. It says COPD heart. C for there is clockwise rotation. That is, there is vertical and rightward heart. O is for overinflation of the lungs, which leads to low voltage QRSs. Also, low voltage QRS complexes are defined as less than 5 mm in limb leads, less than 10 mm in precordial leads, that are chest leads. Then P for P pulmonale, I have already defined it. D is for the deviation, which is RAD. And again, the most common ECG sign is the RAD, right axis deviation. Then H for hypertrophy, that is RVH. Also, there is sometimes pulmonary arterial hypertension. We can also remember this with this H. Then E for electrical alternations, that is poor R wave progression. Then A for the most common arrhythmia that is seen in COPD patient, that is the multifocal atrial tachycardia. It is secondary to hypoxia. And this is one of the common findings that COPD patient will present with. Then next R for is RBB. This is again these two are the late findings or the complications. Then lastly T for T wave inversions. And these T wave inversions are secondary to RV strain. This is the mnemonic for this.